Hi, welcome back to the GSC Live here in Las Vegas, the Global Spine Congress 2022. I'm joined by two very distinguished gentlemen who are very well-known spine surgeons. I'd like to introduce them as Dr. Ray Ha and Dr. Kiran Alluri. Ray, why don't you start, introduce yourself, tell the audience about yourself.
Yeah, my name is Ray Ha, and I am an orthopedic surgeon specializing in spine. Most of my practice, about 30 to 40%, is deformity surgery. I also perform degenerative pathology as well as tumor and utilize minimally invasive techniques for the treatment of pathology. I'm at USC actually with Dr. Wang here, and we are excited to be part of a really collaborative spine program between both orthopedic and neurosurgeons.
Great. And Kiran, why don't you introduce yourself?
Yeah, I'm Kiran Alluri. I'm the newest member of the spine team at USC, and I've known Jeff for 12 years, and I've known Ray for over half a decade, and they both trained me, and now I'm their junior most partner, and do mostly degenerative spine as minimally invasive as possible, and excited to join this live symposium.
So you two work at probably the most preeminent spine university in the world, the University of Southern California. So I'm so delighted to have you guys here with me today. So let's talk about single position surgery. Ray, you're really the one that started that at the University of Southern California. Why did you start that? What was your rationale?
Sure. I guess just to define it for those who aren't familiar, there's a growing movement for various reasons towards the use of anterior column reconstruction, A-lift, O-lift, X-lift, D-lift, however you want to call it, but working anteriorly to improve lordosis, improve correction, and then in the same position, be able to instrument the patient. And there are certainly benefits from an efficiency and ergonomic standpoint, but the real benefit for me was, I was tired of doing T-lift after T-lift, tired of taking care of patients posteriorly. And as a deformity surgeon, the rule really is if you're not thinking about deformity, you're probably creating it. And so this was kind of a solution for me, both in terms of patient safety and efficiency, as well as being able to do a better job, not only just in the short term, but also thinking long term about their alignment needs and adjacent pathology.
Kiran, maybe I can ask you to expand on that, because I can see you at an early stage adopting that. What are the reasons you're interested in it, and what are the financial ramifications of that?
I mean, great question. I learned single position surgery from Ray, but if you look at the data, if you do a traditional lateral position and then you flip prone, there's a study out of NYU that shows it takes an additional 2 hours to flip that patient. And if you think of 2 hours of operative time, that's another case. And so if you can do the surgery in one position, not only are you able to treat more patients, but you're able to decrease your anesthesia time, which leads to less postoperative issues, ileus, shorter length of stay. And so the financial benefits of single position surgery, not only from decreased operative utilization, but also decreased length of stay because of less anesthesia. I mean, you add that up over the course of a year, and it's really something that you need to consider. And so from a financial standpoint, it makes total sense for the healthcare enterprise. And then, like I said, from a patient standpoint, being able to do the surgery quicker and safer with less anesthesia, I think it just leads to better outcomes. And as I said, the data will show you that.
Ray, you're really big on tracking outcomes, which I think is fantastic. Are you seeing a difference with your single position surgery versus your sort of stage surgeries?
Yeah, I think there's a couple things that are probably not captured. Number one, with any position change, there are probably going to be some sterility issues and the potential for increased infection, trays being open longer. So that's one thing we probably don't have the power to detect. I will say that when it comes to hospital length of stay, time of surgery, that's absolutely been borne out. You're at USC, so you share my same frustrations. We do a case, and then you're waiting a long time for turnover, and then if you add a flip in there, it's really actually like doing 3 cases, which is a long, long day at a big university. By doing a single position surgery, this really shortens the time of surgery, less anesthetic for the patient, and I really do think it translates to shorter length of stay and earlier postoperative recovery for the patient. I'll tell you, I do a lot of MIS T-lift. It's hard for me to send a MIS T-lift patient home in less than 24 hours. It's routinely for a 1-level lateral fusion with single position screws, they'll go home within 24 hours.
Oh, that's fantastic. So that's great from a patient perspective, surgeon perspective. Is it more stressful, less stressful? It's kind of nice to have the vascular surgeons doing something while you're having coffee in the morning. It does make for a longer day. Is it more stressful? Do you notice a difference for you as the surgeon?
As a young surgeon in my first year of practice, yeah, I definitely think it's more stressful to do a, L4-5 L lift as opposed to a L4 to S1 A lift. But I think from a safety standpoint, once you get over that learning curve, yes, it is more stressful, but I do really think it's better for the patient in terms of, like I said, operative utilization time, length of stay, etc. Like, my 2-level A-lifts or even 1-level A-lifts are in the hospital 3-4 days just because of that ileus and retroperitoneal swelling. But like Ray said, my L-lifts, they don't go home within 24 hours. I don't know what I'm doing different than him, but routinely within 2 days.
Well, I think Ray is escorting them out of the hospital personally. So Ray, I first saw you start with a lateral position. Why don't you take us through that, why you thought that was the position to start, and kind of your workflow and how you set that up?
I'm a big believer in lateral surgery. I think it solves a lot of solutions. It's a very elegant procedure. But the big drive for me to move a lot of cases lateral is in deformity correction operations in which multiple interspaces are being treated. It's nice not to have to do a rotisserie flip, right? You're doing an L5-S1A lift, then you're turning them lateral and doing additional. And, gone are the days where we're doing a big abdominal incision to get L2 to S1 anteriorly. That's obviously very morbid for the patient. So it was in exploring ways to kind of solve that inefficiency that I started exploring the single position surgery, being able to treat the 5-1 disc in the lateral position with a lateral A lift, then be able to work up the lateral aspect of the spine and do multi-level laterals, and then avoid an additional flip potentially. So that was kind of where I got very passionate about it. I mean, it changed my ability to finish a deformity case in a day, as opposed to having to stage it and bring them back the next day. And that also kind of morphed into, for degenerative cases then, we can learn how to safely and reproducibly put screws into the lateral position, both fluoroscopically guided or navigation technique, and we can do it safely and do it in a reproducible manner. And so that really kind of was the game changer for me, because before you kind of have a high threshold to say, well, I'm going to do a lateral and then I'm going to flip and I'm going to do the work in the back. Maybe I'll just do a T-lift, right? I hear that time and time again from surgeons. But really, when you get to the point where you believe, number one, that indirect decompression is powerful and real if carefully selected, and you can do this in a single position, it really kind of changes the way that you view clinical problems.
Sure. And so that's kind of in the lateral position. That's how you started. And so A-lift, your workflow is the vascular surgeon's working at the same time you're starting the lateral approach?
So if I'm working with certain vascular surgeons, then I will start and do some of the lateral while they're doing their anterior exposure. And depending on if we're flipping for screws, we'll instrument maybe L3 to S1, L2 to S1 in the lateral position if there's not need for osteotomies. So sometimes I'll just be cannulating pedicles while they're doing the anterior. And once they're done with the anterior, then we can work on that and then proceed up and then do the laterals as well.
Because I imagine the real-time savings is not just doing it in one position, but also doing concomitant surgeries, like while they're doing something, not just waiting for them to do it in that position, but actually getting some work done while they're doing that position.
Yeah, and probably most of the time savings come from when they're closing an anterior incision. Sure. Because otherwise the rest of the surgical team is just kind of on pause and waiting to reposition and start working. If they're closing in the front, you can do any manner of, you can move on to the laterals, you can work on the posterior instrumentation.
So Kiran, I want to talk to you about the prone lateral, because doing the lateral position, it's almost like relearning things. The vascular surgeons have to relearn kind of how to do an A-lift in a lateral position. You as the spine surgeon have to learn how to put screws in the lateral position because you're used to having the patients prone. The prone lateral makes a lot of sense because it's a little bit more familiar, but what's the learning curve on that?
Yeah, I'm in a unique position because I learned single position lateral from Ray when I was a resident, and then I went to fellowship and we learned prone lateral. And the advantages of prone lateral are, like you said, it's if we all work in the prone position, so putting in screws is very easy, much easier than putting it in the lateral curve. So there's really no learning curve in terms of instrumentation in the prone position because we all know how to put in screws prone. The learning curve is the retroperitoneal axis in the prone position, and I think that's a huge learning curve. It's a little bit more challenging, one, because the skin doesn't fall away as it does in the lateral position, so your blade length is 20, 30 centimeters longer on average than in the lateral position. So you're working in a much deeper corridor, so visualization can be a little challenging. Two, the working angle, if you don't rotate the bed 30 degrees away and work like this, if you're just working straight on, it's very ergonomically unfriendly to be malleting and doing your disc prep basically straight on. It's actually quite uncomfortable. So you have to rotate the bed 30 degrees away, but then you're working orthogonally, so you have to be careful that you're not going too far posterior and entering the canal, or too far anteriorly and accidentally releasing the ALL. So that's the learning curve. Yeah. In terms of the axis and everything, that's pretty similar in the lateral versus prone position, the retroperitoneal axis, but it's just you're working at a deeper length. The other thing that you have to be a little bit more cognizant of is, we've shown that if you're in the prone position, you extend the hips, so the femoral nerve is more posterior, which you think is great. You think that you have more anterior axis and you're safer, but in actuality, you may not be, because what's happened is the femoral nerve is actually on more tension. It's getting stretched. And so there's no data to prove this, but anecdotally, I think if your retraction time is too long, I don't think the nerve tolerates as much retraction time in the prone position, especially with extended hips, as it does in the lateral position. So these are all very small learning curves in terms of working in the prone position, but the advantages are similar to the lateral position: no flip. You can directly decompress in a position that you're used to. You can simultaneously work. You can have someone doing the, retroperitoneal axis while you have your fellow or co-surgeon on the other side of the table actively decompressing, or you can have them actively putting in screws while you're putting in the cage. So you're simultaneously working, just like Ray's alluding to in the single position lateral. You're still simultaneously working in the prone position, but you're doing different things. The one advantage of single position lateral, doing the A-lift at L5S1, you obviously get in a bigger cage. If you're doing a prone lateral and you're trying to go to L5S1, you're basically limited to a T-lift. So you may not get the lordosis, you may not get the indirect decompression, you may not get the big cage and better biomechanical properties. But to each their own. And I think it's great to know both techniques because they both have their inherent advantages. And like I said, I'm lucky that I learned one technique from Ray and I learned another technique in fellowship. So I indicate differently based on different scenarios. But single position, whatever way you do it, I think it's the way to go in terms of economic resources and OR efficiency.
Yeah, just to circle back on that, we just recently published a study on the early experience of surgeons on lateral single position and prone. And what they found was that the part you would expect people to struggle with, they did. So for prone lateral, they had more transient nerve numbness, neuropraxia type issues. And for the lateral, the early experience was that there were more misplaced screws. Now, I think as the learning curve for both progresses, we're going to see that those complications are going to drop off for both. And I agree with Kiran that at the end of the day, you don't want to just have one trick because there are times in which both are appropriate. I think if you want to harness the positioning lordosis or do osteotomies, it's nice to be able to do a prone lateral surgery. But for other clinical situations, it may be better to do to a lateral single position.
So what's your advice, just to kind of finish up here, what's your advice to the surgeon out there who's watching this and now they're fascinated? They listen to the two of you talk and they're convinced. How do they get started? Do they have to go to a cadaver course? Do they, assuming they already know how to do the surgery, just in different positions? Yeah. Do they just book a case? You advise them to go to a cadaver lab and try it out? And how many cases does it take before they sort of get facile with it?
That's a great question. I think the adoption of new techniques is always going to be a controversial issue. Here's what I would say. It's actually maybe less the technical aspects that are important than the review of the cases. So looking at the anatomy beyond the spine, the crest, is this favorable? Is the vascular anatomy favorable? Am I thinking about all the issues? I think that may be the most important part. There's of course 100 different companies that can facilitate courses, and I urge people obviously to try the techniques in the lab. But at the end of the day, it's really taking those cases, talking them through with somebody who has experience. And there's a number, again, of companies who can help facilitate that and make sure that engagement is there.
I agree. I think, go to a cadaver lab with an expert surgeon, have them teach you the technique, review the indications with someone who's done hundreds of these surgeries, and then, pick. I think they're both good techniques, but I would pick one that you think is most beneficial for your practice, and get really good at it. But don't bounce back and forth, because then you're never going to you'll be okay at both, but never great at one. So I would say pick one, learn it well, learn from someone who's done hundreds of cases, and then go with that. And once you've mastered that, maybe if you feel indicated, go learn the other version.
Well, I think we've just heard a lot of information, a lot to digest there. I want to thank the both of you for taking the time and stopping by our GSC studio here. And I want to thank the audience for their attention, and I hope you tune in for the next segment. Thank you very much.
Thank you.